And you guys are presenting from the room, right?
Yes.
Also, like,
Oh, wait.
Might want to pause the recording.
Okay, hold on.
and I like to.
Okay. We should be good.
I didn't hear anything.
I heard recording in progress.
Okay, good.
Yeah, I heard it. Yep.
Good, good.
Okay.
All right, we're all good.
Great ones you need to find this really. Oh, you got it? Got it. Okay.
Okay, great. Lovely. And then like to give it a big regular. I was like, they're on it. It's like, okay.
Yes.
No, same thing. I was like, let's do it.
So I wanted to go there.
Yep. So you pick that up on the mics. I got myself. So if you need anything, you'll call me.
I will.
Sure.
Did you click back on this screen?
Huh?
Did you click back on this?
Yes, I
screen?
did.
What was this? This mic, this spread?
No,
When you
no.
click that,
I get many of
turning
them.
on the above that. Okay. Which we don't do that yet. I'll go with 12:10. I'll give it another minute to.
Instead of just saying I'm from Boston. Right? Well, the question.
There's one more.
Yeah. Some people. Yeah, I see it. I see it.
I did learn about it.
Can you tell I mean, we're all fine.
Yeah, exactly. Yeah, just. That are not.
8.
8.
Oh, well, yeah, no, mine is actually, oh, no, wait, actually, it's. Yeah, 6. 7, you're right, yeah, 7.
Yeah,
We still got a few minutes, so.
yeah, there's still a few minutes. Wow, dark. Okay.
Yeah, I'm still getting to learn to see that. Not asking it anymore. Thank you for your love. Yes. Got it. Thanks. As you see the and now saying that.
45%. There's a lot of them.
And that is. Yeah. Reality. Yeah. Oh. Not. It's. Thank you, that's what I was gonna ask you. Thank you. This is, I'm coming back to you.
You can't see if you get too far over there.
Well, I'm just gonna come here and like.
All right, all right.
I'm a member of,
Yes.
register too. Yeah, put them left.
But you know what, it's good because people might be in their office, but they.
Yeah.
Just continue.
On the Hopkins. Correct. I want to more than we think. People tell me,
No, I'm. Yeah. Oh my gosh, we met at the advisory board. Thanks, Danny.
Yes, sir.
Oh, that was like, oh, right. No, I know. Oh, yeah, right side, yeah, that's right. And it's funny, I need to watch one last one. Oh, yeah, that's why I just saw there. Yes.
Yeah, it's 75 units.
Oh, okay.
It's Sunday, Monday, and Tuesday.
And I thought if you didn't wait until this.
Oh, okay.
Oh, yeah, that. No. Internet, but it's. That's right. That's right. Just so.
So you're gonna be Thursday.
No, I'm gonna be in Boca. That's when she wants to start. She wants to come on Tuesday. Yeah, let's go on the 6th.
Since university's.
Oh, yeah, that's right, for the COVID thing, yeah. Yeah, that should be good, I read that book too, I'm pretty sentimental.
They're saying they're gonna fill some of these service.
Really?
Oh, yeah.
Oh, the Grange.
No.
That's so good.
Yeah.
So that'll look all right.
Make some more stuff.
There we go. There we go. That was my aim.
Yeah.
I can really read.
Yeah,
These are just, they're just lines.
it's just that, yeah, it's just that. This is excessive.
All right, we've given it a 2-minute lag just because it's a rainy day. But good afternoon, everyone. Thanks for joining us, especially for those of us gathered here in person, made it through the rainy weather. And I see a large number of people who are online. We certainly appreciate you joining us as well. My name is Greg Kurt, Vice Dean for Research here at the school. And it's really my privilege to welcome everyone to our initial seminar as part of the school's Rural Health Initiative. The great thing about the Bloomberg School of Public Health is our breadth, our depth, and our collaborative spirit. And there's been many instances where if I have an idea for a new research topic, I'm pretty easily able to get into the office or the inbox of someone who's an internationally recognized expert to chat about what that grant or paper or research idea might be. We have experts on diverse topics and a robust research portfolio with a focus from Baltimore and Bolivia to Bangladesh and Botswana. We also recognize the notable health disparities by many metrics in rural regions of the US. Compared to this global footprint, our efforts appear relatively less numerous in Beaumont, Birmingham, and Broken Arrow. A few years ago, well before the current administration, we strategized that collaborative research represents an important opportunity to enhance both the diversity of opinions and expertise within the school, as well as to address the significant need for public health research and practice in domestic US settings. While those efforts percolated along for some time, last spring we hosted a Grants 360 session sponsored by the Research at BSPH office. That session was very well attended. I suspect there's many return visitors who participated in that session. And they included faculty, students, as well as external partners, both here in Baltimore and from many diverse locations throughout the US. There was substantive interest on many different topics, and we have a growing list of things to pursue. But at the top of the list was the desire to learn from faculty members with pragmatic experience in translating their global health research or practice into the US rural setting. And we're very pleased that today we actually have two faculty with just such experience and hope to learn from their shared lessons and insights. Importantly, both examples focus on mental health, which, as they will highlight, represent a notable disparity in both US and global settings. But first, I'd like to ask Dean Keisha Pollock-Porter to make a few remarks. Keisha has been with us now in the dean role, I think for many months to years. You'll be introduced as just recently as dean, but we're a few months in now, so maybe we should revise that standard introduction. Hopeful that Keisha will also, like many of you may not know, that Keisha has actually some of her own public health leading public health initiatives in rural US settings. So Keisha.
Thank you. Thank you so much, Greg. I know we're fixing the camera. Can I go? Okay, great. Well, thank you so much, Greg. Good afternoon or good morning, good evening, depending on where you are in the world. I'm so pleased to be with you today for this seminar. I'm really excited because, as Greg said, I've worked in rural communities myself, and I'll say more about that in a moment, but I really see the purpose of today's session as our ability to listen, to learn, to engage, and to really imagine a healthier future for rural Americans by learning from these strategies that have been implemented globally. I'm so excited for our two speakers. I hope you all know that rural communities are a significant part of this country's national identity. Based on the US Census definition of rural, 1 out of every 5 Americans lives in a rural area. And that's 66 million people who are often left out or marginalized in the national discourse, but who also deserve our time and attention. And we must address their needs as well as we hope to live in a more healthier and equitable nation. And while we know that not every rural community is the same, there are many common threads we see between them. We know rural Americans often have limited access to specialists. Many have seen their local hospitals and nursing homes closed. Their suicide and overdose rates tend to be higher, with services hard to come by. Yes, these challenges are great, but rural communities also have tremendous human resources to draw on, and they have strengths and assets that we can leverage. And public health has powerful strategies and solutions to help. As Greg said, I've done some work in rural communities from 2018 to 2020. I worked on a project called Play Streets, an effort to help rural communities that lacked playgrounds and safe physical environments for kids to play in. This idea originated in cities where a single street was shut down as a designated time so kids can be active. We explored how to adapt this strategy for rural communities. And you might say, rural communities, there's lots of open spaces, but kids are pretty sedentary in many rural parts of this country. So we spent time in these communities listening, learning, and we found out that you can't easily shut down a street in a rural community because sometimes it's the only street. What we learned is that we could activate unused spaces like open fields or parking lots to turn them into places where kids can imagine and play. This project was years in the making, and each of the communities we partnered with designed how Play Streets could be implemented for them. In North Carolina, we engaged deeply with a local church and activated underutilized open space behind the church. In Oklahoma, we partnered with leaders from the Choctaw Nation and activated streets and parking lots and open fields. And thankfully, in response to the many hours of active listening and collaboration, we were able to create Play Streets that have been sustained to today. And I know so many of you online and in this room have similar experiences working in rural America, or if not yet, I know you're here to learn and to think about how your work can be adapted to rural settings. And I know that together in community, we will work towards our goal of bringing health and well-being to all people, no matter how small or remote their community may be. And so today we'll hear from Dr. Collins and Dr. Haroz on powerful strategies, And I'm grateful for Greg's partnership, and I want to thank Greg and his team, especially Dr. Vanya Jones, the Assistant Dean for Community Engaged Research, for helping to make today's event possible. And I will turn it back over to Greg and just say thank you so much for being here.
Thanks so much, Keisha. Thanks for those insightful words, Keisha. So we do have two speakers, and we'll also have some time after that for questions and answers, hopefully answers. I'm sure there will be informative answers. First up will be Pamela Collins, Bloomberg Centennial Professor and Chair of the Department of Mental Health, trained as a psychiatrist and with a clear research focus on diverse underserved populations. Pamela works at the intersection of culture and mental health, employing mixed methods, implementation science, as well as leading policy development related to global mental health. With prior stops at the National Institute of Mental Health and the University of Washington, we're thrilled that Pamela has joined us here at the Bloomberg School a few years ago now. We don't have that early introduction anymore. She's been with us much too long for that. But we look forward to hearing about her experiences in rural U.S. settings. I'm going to go ahead and introduce the second speaker as well, and that's Emily Haroz, Associate Professor of International and Mental Health, and heavily engaged in work with the Center for Indigenous Health, trained in psychiatric epidemiology, including obtaining both master's and doctoral degrees from the Bloomberg School. Emily researches the implementation of mental health and suicide prevention programs, particularly in partnership with Indigenous communities. On behalf of the Research at BSPH ecosystem, Dean Pollock Porter, Assistant Dean Vanya Jones, and the rest of those engaged in the Rural Health Initiative, we're very pleased to launch our Rural Health Initiative with global strategies for U.S. public health, U.S. rural health. Please, do we have Pamela come on up? I think. Oh, we should have had that up for the.
There's Emily. Hi.
I could repeat it.
Thank you so much, Greg and Vanya. It's great to be here. Great to have this conversation. And so I'm going to talk about rural mental health in the United States and considerations for low resource settings. My experience in rural communities comes from having lived in Seattle and being based at University of Washington in Seattle, and UW, which I'll come to this a bit later, but UW is responsible for providing services to what we call the WWAMI region. So Washington, Wyoming, Alaska, what do they stand for? Montana and Idaho. So we'll come back to talk a little bit about that. But I was struck by how similar a lot of the concerns around population mental health at our institution were to the concerns that we have when we think about mental health care and developing services in many low resource settings around the world. So these are the key points for my presentation, which is going to be more of a broad overview. So when we think about rurality and mental health, we often think about disparities in access to care. But I also want to remind us that disparities are rooted in complex interacting factors that include care, but also many other things that we want to consider when we're thinking about intervening. Innovations in care have grown from access needs in the United States. We'll talk about that. And the growing global mental health evidence base of the last 15 years or so could be very valuable in informing interventions in rural US communities. However, context matters, as you all know, and we should talk about some of the considerations when we think about this kind of translation. So this is just to remind us, Keisha just made these points that about 1/5 of the US population lives in rural areas. Of that population, an estimated 6.5 million people are living with some kind of mental health condition. And of course, there's less access to behavioral health care. So when I say mental health, I'm thinking behavioral health, people with substance use conditions, as well as mental health conditions. And people tend to have access to providers with less specialized training. The table at the top is from HRSA's 2024 update on the behavioral health workforce, but this came from research at the Rural Health Center at University of Washington. I just want to draw your attention to the comparison of the percentage of US rural and urban counties without behavioral health providers. And you can see that it's around twice, at least twice the amount in rural counties that do not have a psychiatric mental health nurse practitioner, do not have a psychologist, do not have a social worker, and do not have a counselor compared to urban counties where these are much more prevalent. This is the National Institute of Minority Health and Health Disparities Research Framework, and NIMHD considers rural communities a health disparity community. And I find this very helpful in thinking about what are some of these interacting factors that lead to disparities in rural communities. And if you look socioecologically from individual, interpersonal, community, and societally, as well as through these other domains of influence, the biological, the behavioral, the built environment, the sociocultural environment, and the healthcare system, you can see how individual coping strategies might prevent someone from seeking care because of their community norms over here in this, that really prohibit seeking mental health services because of stigma or concerns about interpersonal discrimination, and insurance coverage. I was reading a case example of someone who, if your particular insurance only allows you to make one visit to a behavioral health care provider in a day, and you live in a place where you have to drive a couple of hours to get to any kind of appointment, that means you're spending a lot of time on the road just getting to your appointments, and that's often just not going to be feasible for people. And finally, quality of care. And I want to come back to this issue of quality care when we get to the discussion. So the point here is that when we're thinking about whether our interventions are global or domestic, we want to think about the complexity of the interaction of these disparities, these factors that can lead to disparities. Rural communities are very diverse, and even the definitions of rural communities differ substantially, but some people would say that there's a culture of rurality that may be maybe more common across settings, and that's low population density, remoteness, isolation, a greater prevalence of poverty, religion and the importance of religion, social support, as well as stigma. And in the case of thinking about mental illness, we tend to see higher rates of stigmatizing attitudes around seeking mental health services. And of course, that differs among different subgroups of people living in rural communities as well. But I thought this culture of rurality, these are interesting to consider when we also look at this is the WHO's most recent data summary that and I like this figure because it tells us what are some of the issues that are blocking transformative mental health services around the world. And many of these are similar issues. So insufficient research, well, that's why rural health is part of the Institute on Disparities. We don't have as much research on rural communities and certainly not as much on rural mental health. The governance gap. Where does the money go for supporting mental health in rural communities in the United States? That's not the same as in the global space where a lot of this goes to psychiatric hospitals, but I think we could ask this question: where do the dollars go in these settings compared to other settings? A resource gap, a scarce workforce, very true in low-income countries, very true in the in the rural space here. The digital divide, also true. In the United States, about 10% of all children and adolescents live in a county that does not have a psychiatrist, and a county that does not have bandwidth for telemedicine services. When you look at children and adolescents in rural areas, more than 50% live in those kinds of counties where there's not access to or certainly a child or adolescent specialist, and no access to telemedicine services. So this digital divide is very real for us. And then finally, the question about the services gap, that people not receiving the services in rural areas. And I want to come back to the question of quality, as I mentioned before, because I think that also people's perceptions of what quality care is also determines what's acceptable care, right, in these environments, and also informs the way we think about translating innovations. So this is the WWAMI region. It's a massive expanse of land when you think, and fairly sparsely populated. Alaska alone is 20% of the land mass of the continental United States. So you can see that this is a huge swath of the country, comparatively speaking, and there are very few specialist providers. One of the probably best tested innovations that grew out of this area in the University of Washington is the collaborative care model for mental health, for extending mental health care. And this is a model that says if you don't have specialist mental health care providers, how do you use the providers that you have who are generalists? So this tends to take place in primary care, but also there's evidence for OBGYN, for other basically primary care services where this model can take place. And it's a patient-centered team-based care model. It's population-based, meaning that you need to understand who your population is, and it's measurement-based so that you're providing evidence-based interventions, but measuring the treatment target. And it's accountable care. And it tends to be applied, as I mentioned, in primary care, but also in non-communicable care settings, HIV care, OBGYN care, many other settings. But this has been shown, and the way this works is that you have a practice, and you don't need to have a psychiatrist or a psychologist in that practice to deliver an evidence-based mental health intervention. That could be a psychological intervention, which would be delivered by the care manager who's in the middle, or if your team happens to have a therapist, it could be the therapist. But the primary care provider is going to be the main person responsible for providing leading the overall care. And there's the patient at the top, and the care manager is the glue of the team, the person that ensures that the patient is adherent, the person that, as I said, is sometimes also playing the role of the therapist, but really is ensuring that there's communication amongst the members of the team. That person's quite central. And the psychiatrist, or whether this could be a clinical psychologist, whoever the specialist is, isn't actually physically present necessarily. That person can be contacted via telemedicine, but that person consults when there's an issue, and that person reviews the patient roster with this team on a regular basis and make sure that, if we're actually not treating to target, what's happening and how can I help, redirect or inform the treatment approach. So it's been tested in, I think, more than 70 clinical trials in the United States, and now is, of course, being implemented in many places in the US, and is also reimbursable now through Medicare. So that's a wonderful intervention. It is increasingly being used. Let me get back to my pointer here. It's also increasingly being used around the world. And this is just a graphic showing the number of collaborative care model trials happening in these regions of the world, in Latin America and Sub-Saharan Africa and in Asia. There have been about 12 RCTs, and people have had to adapt this to their region, right? So it's always a multi-professional approach. The team members may not always be the same as in the US version, but there's a structured management plan using evidence-based algorithms for care or protocol-guided therapies. There's scheduled patient follow-up, and there's this enhanced interprofessional communication that the care manager is responsible for, just to make sure that there is adequate communication between the team members, and that there are case reviews that occur on a regular basis. And in these settings, it's been found to be significantly more effective for treating depression at short term, 0 to 6 months, medium term, following people up to 1 year, and even the one long-term study of up to 2 years. This also reduced depressive symptoms significantly compared to usual care. And in these studies in low and middle income countries, most folks have said it's the case manager that's the key. It's that person who follows up, who administers psychosocial interventions, who communicates with team members, who really has that close interaction with the patient or the client. That's a key member of the team. So over the last 15 years, the global mental health research community has really built a strong evidence base around task shifting, this idea of using people with less abbreviated training to deliver mental health services. And when I say more abbreviated training, that can be people in the general medical sector, as we've just talked about, primary care doctors, nurses. But when we look at who the providers are in rural areas, these are general medical sector folks, but they're often friends, they're often family members, they're often spiritual leaders. And these are people that we're also seeing move into these roles of task shifting. There's a wonderful study that when I was at NIMH, we funded in India and Pakistan, inviting peers, moms in the community who've had kids, to become the therapists for pregnant women with depressive symptoms. And that can work. I think we're learning that all kinds of people, all kinds of providers can help to support evidence-based therapy with the right evidence-based interventions, with the right support and the right training. So examples of task shifting in the rural US are community health workers who've been used for stress management, substance abuse, domestic violence, depression and anxiety, promotoras. And Alaska has a system of behavioral health aides, as well as the collaborative care providers that we've talked about. Washington State is now experimenting with a new bachelor's level clinician. So somebody that instead of going and getting your 4-year degree in psychology and then not really being able to get a job, you actually get a 4-year degree that gives you clinical skills and a license that you can begin to do some of these low intensity evidence-based psychological interventions as a provider. So they're in the midst of piloting that to see how that can be utilized. That is, of course, another type of task shifting. So I want to just close with this slide saying that task sharing has been quite a successful innovation globally, certainly with respect to research. The sustainable implementation is another challenge, right? How do we actually sustain implementation of these models? How are they paid for over the long term? But in high-income countries, it's sometimes portrayed as a deficit. You're not getting the highest level of specialty care. And that raises the question is that when we're providing people with care that has people who have less specialized training, is there a real issue in quality of care? Is that a perceived issue? And I'm sure sometimes it's both. So I think that's a question when we're talking about translation, ensuring that people are getting quality care, irrespective of the provider, is obviously a very important concern. Other concerns with task shifting include professional boundaries, confidentiality in isolated communities where if you live with the people that you're providing care to, this has often been a challenge in Alaska where here's an elder and really am I going to actually be am I as a 30-year-old, going to be the person talking to this elder about substance use issues? There can be challenges in that with respect to those issues. And how can rural and global interventions address these socio-ecological domains of disparity that we've talked about? I think there are shared lessons to use, but these are questions that we can be thinking about as we think about interventions. So thank you. And let me move the slide for you, Emily.
Thanks so much. And we are going to defer questions till the end. Emily.
Thank you. Well, thanks so much to the Dean and the Vice Deans for having us here. And Pamela, that was an amazing talk. I feel like we planned this because it's going to lead right. I'll talk a little bit more anecdotally about some of our work at the center and my own work and how it's shaped my thinking in this area. Real briefly, I have lived in rural America with my family. We moved out there with a family of 3 kids and a husband and lived and worked in eastern Arizona, right near the White Mountain Apache Tribe Reservation. So those roads, I was thinking about Dean Porter mentioned, like thinking you could close one lane, but then people get pissed at you. So anyway, so globally, I'm just going to talk a little bit. Globally, the challenge we face in mental health is staggering. Pamela talked a little bit about that, but it's estimated that over 1 billion people in the world have a mental health condition. But the median number of mental health workers is just 13 per 100,000 people. So this is a massive treatment gap. In my early work, in my early days, I'm way back there as a PhD student, I focused on the only logical solution, which was at the time task shifting, which I'm glad Pamela brought up. The idea is to train local trusted community members, paraprofessionals to deliver essential, often manualized evidence-based care with enough supervision and support. And over the last 2-3 decades, there's quite a bit of robust evidence for task shared or task shifted interventions in low and middle income countries. Most trials say they're significantly associated with larger reductions in depression, severity, anxiety, trauma, substance use, and many other outcomes. And in fact, sometimes I like to say this, I think that there might be so many trials of these types of approaches that in some ways we have some of the most robust evidence base for any type of approach I've ever seen in public health. So I think at this point, it's probably 30+ trials on those things. So we have really a global problem and a really proven global solution. But as we know, and as Pamela pointed out, in the US, we face very similar challenges. Rural America encompasses nearly 75% of the land area of the United States and is home to more than 46 million people. Broadly, it's estimated that there's about 1 mental health professional for every 140 individuals with mental health issue. But in rural settings, as we heard earlier, about 69% of counties lack a psychiatric nurse practitioner or other psychiatrist. So there's a huge amount of missing sort of professionals. So these are the exact conditions when task shifting is designed to work. Also, I'll just say that more recently, I think we face another perhaps a more profound barrier, which is a deep and growing distrust in public health, especially in many rural communities. And this is often rooted in the history of disinvestment, a feeling of being left behind, and a healthcare system that feels designed for urban centers, but not by or with rural communities. So this is creating a crisis of trust. This is where my work at the Center for Indigenous Health has come in. Well, it's really important to recognize the great diversity of American Indian, Alaska Native peoples. A majority, actually, this is often miscited, live in rural and small town areas. And so about 60% of American Indian, Alaska Native live on or near their tribal homelands. And I'm fortunate enough to have joined the Center for Indigenous Health about 10 years ago and learned a ton from all my colleagues there. So this is not my work that I'm representing, but I'm happy to be here to share it. So our center works in these settings, building long-term partnerships. So in thinking about how task shifting in these communities could work, the question we faced wasn't just like, is it gonna work here? Because that's clear. But the real question was, how do we implement it in a way that's sustainable and trusted in the US context? Because task shifting isn't just about training someone to deliver an intervention. In rural settings, especially in communities with historical reasons to distrust public health institution, it requires deep, sustained investment in local infrastructure, rigorous training and ongoing supervision and support, not parachuting in with a program and leaving. And of course, all this takes time. But this is the work that I've been working on with my colleagues for the past decade. So one example of this is the the Center's Family Spirit Program. It's an evidence-based home visiting program originally designed for American Indian teen moms after the local community prioritized this population in particular. I've got to go to the next slide. No, I don't got to go to the next slide. Sorry. The program was tested and delivered entirely by Native paraprofessionals. So this is an example of a home visitor going to meet a pregnant mom in a very rural setting, as you can see. The most robust randomized control trial of Family Spirit proved the model's effectiveness. So mother had greater parenting knowledge, higher parenting self-efficacy, and their young children had fewer internalizing and externalizing problems associated with longer life issues. Given all this evidence that was generated, the program's now on these national registries of evidence-based programs here in the US, supporting tribes and other communities to access state and federal funding through MCV or the FFPSA, which are federal funding policies. And it's now scaled to over 170 communities around the US and 10 communities globally. But we didn't stop there. As Family Spirit has grown, partners have continued to tell us that families need more intensive mental health support. We hear often that moms get screened because that's part of these programs, but then there's nowhere to go. Or the wait lists are super long, or they don't want to go because there's stigma and people don't understand the cultural context. So leveraging the knowledge of the work internationally from my work as a doctoral and postdoc, doctoral student and postdoc, we adapted the Common Elements Treatment Approach, CETA, which is a proven modular mental health intervention designed and tested for global low income settings, and we created Family Spirit Strengths. This is pretty heavily adapted at the time, but it's been a real joy to work with the CETA team on really creating something unique to these contexts. So we're running a randomized control trial of strengths. We are at 85% of our target sample in the last 2 years. So we're really excited about that. But a central part of the work is the delivery mechanism of strengths. So instead of just a one-off, you meet with a therapist, which was done, we actually embedded it with the same trusted relationships of the home visitors themselves. So it's really designed to be integrated into home visiting. So these same local home visitors already knew that the families already knew can now deliver and tailor this mental health support for depression, anxiety, substance use, and trauma. And it's really designed as a secondary prevention program, trying to reach families before it escalates and trying to reduce symptoms while they wait maybe and get referrals to more specialized care. So now, now I want to just share what I've learned about from the decade of work I've done. When I came to the center after 7 years in global mental health, I was focused so much on the task, like with the actual intervention that was being delivered. But my colleagues and community partners taught me something very critical. I remember this very clearly. One of my brilliant colleagues, Crystal Austin, told me, it's not just the task, it's the relationship and it's the trust. You can't shift a task to someone in the community who isn't already seen as a trusted partner. And we're fortunate that with our strengths work and many other new programs to build on the decades of partnership that has been developed with the center. Our center's strategy isn't just research, it's having and maintaining local physical offices. It's employing and uplifting people from the community. It's showing up to the high school basketball game or championship parade. That was a highlight for me. The funeral, the community parades, and it's not just research. More recently, it's about responding with food boxes when SNAP programs expire and when COVID hits. And recently I was on a call with a community advisory board and someone was recollecting a story 30 years ago where somebody from the community came up to one of the doctors on our team who was Danae and Navo. And the person said, "Oh, it's nice to meet you. Are you Johns Hopkins?" And it felt like this moment of like, that's an amazing partner. That's amazing relationship where they're actually seeing Johns Hopkins, not as a research provider only, but like this is somebody in their community. More recently, it's a service provider. And sort of that story really stuck out to me about what these partnerships mean. So let me tell you, let me show you the power of this insight with our most striking evidence that's very recent, and I'm really excited to share this. So in our recent suicide prevention trial with the White Mountain Apache tribe, we tested brief interventions for youth at high risk of suicide. The interventions were delivered by this amazing team of paraprofessional community mental health specialists. Some of these people are faculty at our center. They tested this for 5.5 years during the height of COVID, driving thousands of hours to serve 304 youth across a reservation that takes about an hour and a half one way to get across. And while our culturally adapted intervention, New Hope, which is a very brief intervention, successfully reduced suicide ideation, the most profound finding came from a post-hoc analysis we did, where we used propensity score matching to compare all the youth in our study whose only intervention was who got a different combination of interventions, but the most thing they got was support from community mental health specialists. And we compared that to similar youth who weren't enrolled in the study. And the results were pretty staggering. So just the active connection to that local person was associated with a 57% 0.5% relative reduction in suicide attempts and 95% relative reduction in the risk of death by suicide. Unfortunately, during this time, there were 32 deaths in the community among youth 10 to 29, and we had 0 deaths in our study. So in an era of profound public health distrust, this is the answer in a lot of ways. The global model of task shifting is obviously a vital tactic, but it's not just the what or the characteristics of the intervention. It's the nurturing of these trusted relationships that I think really will make this make us all have a key public health impact. To bridge the trust gap and reach more in public health, we must invest and empower and trust and uplift members of the community who have been there all along. And so thank you. Skip the next slide. I don't know how to get out of it. Yeah, there we go.
Thank you so much, Emily and Pamela. We're going to transition to some questions. Going to ask both of you guys to take some seats here in the middle. And we're going to open it up for questions. Who's going to monitor the chat? Okay. Do we have anything from the chat yet? Okay. We're opening it up for questions. Please let us know if you have anything specifically. First off is Pamela or Emily, do you have questions for each other or any clarifying questions?
I actually love that Emily used the example of the hubs for suicide, because that's an example of something that we developed at NIMH, starting with global communities and saying, hey, how can we do these hubs that really focus on research that's grounded in the community, but also building meaningful collaborations with people in your environment, in your ecosystem. And then we actually thought that that would be a great model for using with American Indian and Alaska Native communities. And here it is. There it is. Doing great work.
Go ahead, Vanya.
Thank you both. This was so fantastic and so many wheels turning. So we don't have a bachelor's degree at our school, right? But we are investing in micro-credentialing. And I'm just wondering, I heard both sides of your discussion around it's important for it to be trusted, which I think, is probably really true in most communities, but also really true when we have fewer people, right? Married with, skills, right? And so if we say, as we've debated, I thought about for what you were talking about that we can uplift at the school. What would be some things that you think we might want to consider, knowing the little more complexity that would be for sort of rural communities to pull off, that type of training?
Yeah, it's funny because as you were thinking, I was thinking about, if we had such a program, how might communities nominate someone that they would like to receive that training, perhaps, right? And so it could be that you're getting the relationship piece built into the applicant because the community selects the people that they would like to see trained, in addition to obviously getting the training that you need for these delivering evidence-based interventions. But, I think that's something that we've learned in a lot of task shifting work, that there are some people that are really good at it, and you kind of have to go with the people that have a heart for this kind of work as well, right? It's not just something that you can impose, okay, we're going to train 12 people to do this work. There has to be some commitment.
Yeah, I was going to say I think it's a great idea. And I think there are models out there right now run by states often who are creating these sort of like different tiers of mental health or behavioral health aids in a lot of ways. IHS runs a CHR program that does this in Alaska as well. Some of the challenges with it, I think it's great, but is sort of the sustainability of these positions, the ability to progress in these positions, the ability to get paid in those positions. So where is the career trajectory basically for someone who's taken that role? But there are also other models like peer support specialists. Those people get certified, right? Those are models, but I think that's what we've found lately in the US is how do you actually support it so that people feel like they can keep working and progressing in a career, and not just solve the initial problem.
Yeah, I think
Emily?
the payment's a big issue. And I think right now I'm trying to remember the number of states that are that have policies
Yeah.
to support, to actually pay community health workers. And I know Maryland has been working on that as well.
Yeah.
Emily, was there much, Pamela's comment that not, like some people are just good at this. Was there much transition for your trusted home visitors once you added sort of mental health components to the other activities that they were already familiar with? How did their comfort levels, both in both directions?
Yeah.
Like it's a little bit different to be asked about depressive symptoms than it is about some of the more mundane health related topics.
Yeah, one of the interesting things of our trial that's ongoing, and we don't have a big enough sample to control for exact like delivery mechanism, was we actually stood up to home visiting programs that are just delivering the intervention. So they're kind of a standalone, but then we're working with another that's like already an existing service provider and home visitor. And what we think anecdotally, although I'm not allowed to see too much of the data, is that when people are embedded in home visiting already, clients tend to engage better and stay in the program better. So so our home visitors, the ones that are delivering it, we're already delivering a regular home visiting program, they've actually kind of jumped at this because they have felt ill-equipped to navigate this. Like the only thing they could do was say like, here's a referral. And then each week the person would come back and be like, I didn't do anything with it, And so for those people who have like experienced home visiting and seen this a lot, they have felt like now they have the skills and tools to do it. And we're seeing that moms and families are like much more likely to like be engaged in it and not drop out in some ways. We're going to disaggregate it at some point and test that. But so that's sort of what we're experiencing right now.
I want to just add to that because it's a really interesting question. We were doing work in Vietnam, essentially adapting the collaborative care model for perinatal mental health in southern Vietnam. And these were community health workers who had some relationship with the women that they would see in our practice. But when it came to depression screening, and I've seen this in some communities in New York City as well, people just felt very uncomfortable because they felt like, oh, if I'm accusing this person of having a mental disorder, oh, I'm doing something that is stigmatized in our community. And it was an issue.
Yeah.
Like, how do you move from just talking about maternal health and well baby issues to mental health problems?
Sticking with training issues, I think it's a great suggestion that you could nominate someone from the community. But it's, and certainly there's pretty good data that in many cases health outcomes are improved by having a provider who is similar to you or from the same, same location. But that's not always going to be feasible. So on a broader scale, what are some thoughts about training issues? How, like we talk about teaching cultural competency, but it's not that easy to go and spend 10 years. Like that's not a scalable model either. That you go and spend decades getting to know the community. How can you, micro credential is great, but how do you do the cultural competency part?
I don't have great solutions, but I think there are great programs, including like UW, which trains residents to go out, trains students to like have placements. Like when you get to a rural place, it's like totally different than here, right? And there's like real barriers. You experience it, even if it's for like a month, you still like experience some of it. You're obviously not going to get all of it, but you have a different understanding. Like in the communities where we work, people get helicoptered, flown out to hospitals for like specialty care. That's a massive investment. And like to see that in person and be like, oh, I understand what this looks like is like very different than like an ambulance picking you up and driving you to like an urban hospital. And so I just think like even a month, like, or whatever, there's some ideas of this, like you can get some of those experiences that can give you a different understanding of what this looks like. It's
critically important to potentially drive those individuals with that short-term 1 month rotation to pursue a career or a life path that lands them in those rural communities. Of course, it's also just sort of parachuting in, and in many cases, what is received by the community is less than what is gained by the person who happens to come in.
I think that is why.
ahead.
Oh, that question. I was just going to say that's, programs like that, like University of Washington, where you have such need in so many states, right? as a resident, you can go and spend 2 years
Yeah.
in Montana or something. And those people are more likely to stay. They're more
Absolutely.
likely to stay and take their first job there and then be a part of that community.
Okay, we have a few questions in the chat. The first one is from Owen Scott. Are there any organizations you would recommend as community organizations or representatives for this marginalized community, rural Americans? Any organizations that are leading in research and policy advocacy to find solutions for rural health?
That sounds like broad national organizations, whereas I would tend to think that many of them are very locally focused, but I defer.
I think is an organization that leads sort of all of Middle America, rural
Alliance.
and then
Yeah,
Alliance,
yeah.
that's what it called.
I'm sorry, what was that? Heartland Foundation Alliance.
Yeah,
Is that with the Alice Walton New
Yeah,
Medical School?
exactly.
Okay,
yeah.
Okay.
And
thanks.
many universities, I'd say like UW and other ones, are thought leaders in that space who are working on sort of broad-based, are like regional, but have a large geographic focus.
But otherwise, I would say at the state level, lots of people have those kinds of programs.
This next one is from Leticia Fernandez. What have been best practices for privacy and mandatory reporting?
Great question.
Yeah, that's a great question. And I think part of that is training, right? And then helping people to understand that actually confidentiality is a competency. Learning what it means, learning how do you actually exercise it. It's a competency that people have to gain. And people have to understand, it has to be clearly defined. What does it mean? When do you break confidentiality? Under what circumstances? And what is privacy versus confidentiality? So I think these are competencies that you train. Actually, those are some of the foundational skills that we think of when we think of competencies for psychosocial intervention providers. And then how you enforce that is another question.
I'd say it's also particularly complex in small communities, right? And where people are related to each other too, because you're like, oh, so-and-so, I know them personally. And so it's like really drilling, sort of honing in on those competencies. We have something we've been developing on the social support visit structure for home visiting. So if a home visitor goes to a home and the person's in crisis, you're not talking about perinatal mental health, or you're not talking about how to diaper the baby, you're like responding to like a crisis. And so we've worked on laying out very specific protocols for home visitors, and then also having them actually practice the skills quite a bit, like verbally do this quite a bit through role plays and otherwise.
Thank you. This next one is from Susan Buchholz, who I see with her camera on. Susan, would you like to ask your question yourself?
Sure, thank you. Sorry, it took me a minute. Thank you for this great presentation. I'm so excited about everything you're talking about. I'm in Massachusetts. I was asking about whether or not there has been any use or consideration of use of the evidence base for mindfulness-based stress reduction. Here in Massachusetts, we are exploring arming community health workers and peer recovery support specialists with these trainings, not just to pass along, but for their own well-being. I don't know if this has been seen in other places, but here in Massachusetts, we have had kind of an explosion of suicides from peer recovery specialists who have found the work overwhelming and don't have the tools and are exposed to a lot of triggers.
That is a really great question. And I want to say a couple of things about that. One is that when we're training people in these more abbreviated situations, what we call supervision, right? The clinical supervision is so important, because that's typically the place where you get a chance to, your supervisor is the person who's asking you, how are you doing, right? How are you managing these issues? They're hearing about the clients, but they're also ensuring the well-being of the provider who's delivering the care. So that's important. And when that's not robust, then I think you can obviously get into some very serious problems. I think the second thing that I would say that experienced people have learned with task shifting is people are learning to deliver these skills to others, but often talk about tremendous benefit of using these skills at home, using the skills in their in their families. We have an active study right now in Kenya where we're training a variety of kinds of providers to deliver a brief psychosocial intervention to adolescents living with HIV. Many of our providers were laid off with the recent cuts in USAID funding and interruptions in PEPFAR funding. And they're now saying that, oh my gosh, if we hadn't had these skills, I don't know how it would have been so much worse. But we also have, through this entire study, and we'll figure out what that looks like. It's an implementation study, so we'll see what that looks like going on. They have access to supervisors who are, who function like coaches, and those people play an important role in reducing the stress and keeping people from feeling overwhelmed and overburdened with the caseloads that they have. So I think that's an important piece that just cannot be overemphasized, is ensuring the supervisory support network for task-shifted providers.
Yeah, I 100% agree. And I'd say one other thing about that supervision is it makes sometimes paraprofessionals or task-shifted mental health workers are in very hard situations, and having to make decisions with all their training, it's nice to not make those decisions alone, and to have someone that you can call, because those are very heavy decisions to make. And so just like we would with a psychiatrist, an attending, or, anybody, like we would give them support. And so that supervision, I think, is like really, really critical in these places. And something we don't have great models for, I'll say, in the US, like we don't have the best models to think about, like, how do we make sure that all our home visitors that are going to be doing this are going to get a supervisor? We're like actively thinking about that right now.
Yeah, I think also in the peer example that you gave, those are folks who are so highly motivated as well. And often, the boundaries become so important, right? To help people figure out how do you exercise boundaries and get the support you need? Because when you've been through the experience, you can often be willing to go beyond what might be safe.
When we think about task shifting and the scarcity of specialists or providers, there's a lot of interest and money flowing towards, well, of course, there's telemedicine, telehealth types of approaches for extending, but there's also chatbots and AI agents that are going to solve mental health problems and have certainly been associated with some really serious negative outcomes. Any perspective, particularly, is there anything special about rural health? I'm just wondering, like, you're in an even more remote area. I haven't thought about it, but any perspective? That's maybe a whole session.
Yeah, I would love to actually have a whole session.
Yeah, we can follow that up.
Yeah, I think one thing I was just talking to Pamela about earlier is, like, I think there's a narrative that, like, telemedicine and telemental health is going to solve rural America's mental health problems. And that, I find, like, given all of the experience we've had, like, people, that's not going to solve the problems, like, let alone the bandwidth issue, the fact that people don't have internet, the fact that, if you're going to sit as a young, just say, like, in our experience, like a young kid who's indigenous being put in front of a big screen, seeing a white male doctor from Florida calling in, like, there's a lot that isn't going to work there. And so I think, like, I would love to run like an actual study comparing, those types of things to try and say, like, look, this isn't the solution necessarily. We need to think about investing in people and communities first, and having them feel equipped to help navigate these issues.
Great. I think there were a few more questions online.
Okay, we have.
Pick out a good one.
I'm going in order.
No.
Okay, so there's a speculative question from Allison Barlow. What is sustainables to build the capacity of communities to run and sustain this work? Can we tap into reimbursement models such as Medicaid to sustain the workforce? And Leticia Fernandez went on to say underneath this question, how has the withdrawal of Advantage plans from rural areas impacted this as well? And then Kiana also contributed a comment to this thread. Refunding, heads up to everyone about the Rural Health Transformation Program for an upcoming possible revenue source to be approved, states.
Yeah. seen.
I mean,
Any comments in the last couple of minutes?
I mean, there was a lot of advocacy through going to, at least, when I was in the federal government, actually going to CMMI, taking data, trying to present, this is a great case for reimbursement, right? So if you could, this is the evidence, tremendous evidence base, can this be reimbursed? And eventually that happened. So I think with some of these other models, similarly, it's possible to see the law change, right? When we make the case with evidence. I'll stop there.
Yeah, I think there are billing codes in certain states that allow for like case management, patient navigation, things like that, that like organizations have started to tap into a little bit. The Rural America Fund, I think, is excellent and is going to go to states, which is great. I have heard a little pushback just from us that like it's not going to tribes in the same way, which is unfortunate because tribes would really benefit a lot from having that kind of resource and money. But I would say there are some models out there where people have stood up basically like community health worker organizations that can bill. And sometimes they can bill under a provider, like a licensed provider, in a way that will increase the rate of that, and often billing Medicaid for that.
Well, thank you very much. Thanks. It's been a wonderful tour. I want, on behalf of the Dean and Venya and myself, we really want to thank Pamela and Emily for sharing their expertise. Thanks so much. And we want to highlight that this is the first in a series. Amongst the highest, so global to US rural translation was identified from our initial session as sort of the top. Very close was a discussion of sort of rural health, health policy, rural hospital, the rural transformation. So I certainly think that was a pretty close second in terms of identified topics, and technology and task shifting, I think, is clearly another topic for another time. We'll encourage you to stay engaged. There's a QR code here. We have your email if you registered. If you didn't, please reach out to us. And we look forward to continuing this discussion. Thanks very much.
Oh, amazing. I mean, not that I was questioning the answer ever. It was so I think we have an opportunity to cut lips. I actually think this could be something that can, from both of your presentations in the discussion, that could live on the website. Yeah. Oh, cool.